Hi, Llewellyn.
How are you, John?
How you doing?
I'm all right. All right. How are you?
Good, good. I just texted Borlix and asked her to come in. So how you been?
Yeah, I've been okay, you know.
It's the end of your day here, right?
Yeah. It's 7. It's almost, well, it's a quarter to or 25 to 8 now.
Oh, okay.
Mhm.
You're in Pretoria, huh?
I'm in Pretoria. Yeah.
Yeah. It looks beautiful. Like
It's a
Cape
nice
Town.
place.
Wow.
No,
Cape Town, what an unusual location, huh?
magnificent, man. Magnificent.
Yeah, it's unusual. You never see a location like that.
Now, that's the most beautiful city in the world, John. And
Really?
that's not a biased opinion.
Really? It
Yeah, yeah.
looks it looks like it. It looks like it for this picture. When I ran across it, like, whoa, this is different. Let me get call. Yeah, we had a 2-day pediatric neurosurgery conference in Latin America, like
I saw that.
4 years ago,
Yeah, yeah.
before COVID.
Mm.
And we had a full schedule, both days, like 8 hours one day, 8 hours the next. And it was fairly straightforward. It wasn't it's same as now. It's pretty straightforward, not too complicated. I'm entering. Yeah, we have a good one on Friday, Dr. Lawton with
Okay.
Yuha. With
Yeah,
Yuha.
yeah.
Yeah, it's always good to have a questioner like Yuha asking questions and commenting.
Mm. Yes.
Yeah, and there's Ben Zhu is there too. He's a big Chinese bypass. Do you know? Are you familiar with him at all? Ben Zhu. He's a Chinese neurosurgeon. He specializes in cerebral bypass.
Okay.
Oh, yeah. He makes comments too.
Okay.
Oh, how you doing, Griselda? Can you hear me? Probably not. There we go.
I'm sorry, but this is.
How you doing, Griselda? Ok, vas a entrar, ¿tiene el link?
¿Cómo?
Sí, hola,
Sí,
¿puedo?
tengo el link. Te voy a entrar por el link. ¿Ok?
Okay.
Right? Have you got earphones, right? Mm. So how many registrations did we end up with eventually, John?
What's that?
So how many registrations did we end up with eventually?
Last I looked, it was like 150.
Okay, all right. We should be okay.
Yeah, I'm just doing all the administrative stuff, like letting people in. Oh, there she is. Okay. Hello, welcome, Griselda.
Hola, buenos días.
Buenos
Buen día.
dias. Yeah, I'd like to introduce you to Llewellyn. He's a pediatric neurosurgeon from South Africa that helped put this together. And Griselda is a pediatric neurosurgeon who I've worked a lot with putting congresses together. So I'm glad you guys could meet. I'm glad you guys could meet each other.
Thanks so much. I'm muted. Thanks so much, John. So Griselda, it's such a pleasure to meet you. We should look at, via John, looking at setting some sort of conjoined thing up between Mexico and South Africa. I think that would be really nice.
Sure, sure. We can do it anytime you got the interest and the organizational skills that you guys have, like putting this together. And Griselda, we put together, I mentioned to Griselda, to Llewellyn, how we put together a couple of conferences in pediatric neurosurgery that were full the whole weekend.
Yeah.
Yeah, I don't know if you stayed with all of them, Griselda, but I think you came to a lot of them. 2 days. So how are things with you, Griselda? How are things calming down in Mexico a little bit?
What?
Things are calming down in Mexico.
Oh,
Yeah, yeah. I'm not even going to talk, Griselda. You are the neurosurgical TV representative.
oh yeah.
No. All you do, I'm going to say, go. And, hi, I'm Griselda for neurosurgical TV, and then introduce Llewellyn. However you want to do that. You've looked at the schedule. You may, well, basically you're hosting for neurosurgical TV, and your job basically is just to introduce Llewellyn. Now, I imagine, Llewellyn, you're going to kind of host it and moderate after the talks, right?
I think so. So between myself and Mohammed, so I'll introduce Alfiki, and then you'll see the two of us are actually speaking. So I'll do an introduction of Mohammed, and he'll do sort of likewise for me, just a brief thing, and then I'll introduce the speakers from from Egypt, and he'll introduce the other speaker from South Africa.
Okay.
So
yeah, that sounds good. That sounds good. Yeah. So basically, Griselda, Llewellyn runs the show. We just introduce him. That's all. And so, of course, you're welcome to participate in the discussions. If you're going to have discussions after each talk, or you're going to at the end. I forget how you did it last time.
We plan to have them at the end, John, but they tend to sort of surface in between anyway. So we've been relatively flexible, just to allow as much interaction as possible.
Yeah, play it as it goes. Play it. You never know what's going to happen.
Yeah. So Griselda, which hospital are you based in Mexico?
You're muted. Okay.
I work at the pediatric hospital in National Medical Center here in Mexico City, and we depend from the Mexican Institute of Social Security for the public health.
Yeah, I used to know, well, I still know him, but I used to be in regular contact with a guy who may be at the same institution, Rolando Jimenez Guerra.
Yeah. Yes, I know. Rolando was my resident training in pediatric neurosurgery for some time in my hospital, and now he working at the National Institute of Perinatology with neonatal neurosurgery.
Okay. Yeah. So like I was saying, Griselda, we must, if there's some sort of collaborative effort we can put together, I think Mexico and South Africa are good have a similar, similar, I think platform that we work off. So it'll be nice to sort of try and coordinate something.
That's great. Mexico City is very active. Most of the neurosurgeons that are active on media and Zoom are from the Mexico area, including Griselda, part of it. But well, probably more than 50% of the audience in conferences is Mexico. And I guess Luis Borba is taking over, right, Griselda? He's going to be he's vice president now of education. Is he going to be jefe de flank?
Yeah, he's a vice president.
President, yeah. Yeah, he's very You know Luis Borba, right, Llewellyn?
Yeah, I know the name. Yeah, but
Yeah, he's a very good administrator. He looks like a good administrator. He's really, you've met him before, right, Alma? Yeah, I think she's met him before, but he's going to be a great head, and he's really sharp on tech. So, and he knows the value of it. So I think he's going to be good at this time in history to be the head of neurosurgery education. There's a big organization, FLANC, includes all the countries, right? It's every Latin country. Does FLANC include Brazil? Because Brazil, as you know, is Portuguese. Does that include Brazil, FLANC? You're muted, Griselda.
The actual president of FLANC is Dr. Antonio Soriano. He is a Mexican neurosurgeon, and he performs many courses in Latin America, and the next year will be held the meeting or congress from the FLANC, and probably in Miami the next year with Valerio. Do you know
right. Yeah, Jose.
Jose Valerio, sí.
Yeah, he's at Larkin Hospital.
Sí, él va a realizar probablemente el siguiente año el congreso de la FLANC en Miami.
Oh, okay, good. Very good. That's the in-person conference, right? It's scheduled?
Yeah.
Yeah, okay.
And the next, in 2022, will be held the World Congress of Neurological Surgery in Colombia.
Oh, okay.
En marzo.
Yeah, it keeps moving around. You've been to Mexico City, Ecuador, Bolivia. Was Bolivia? Did you have it one year? Bolivia? Yeah.
El próximo año es el Congreso Mundial en Colombia.
Oh, okay. It's a SLUNC or pediatric?
No, es de la Federación Mundial de Sociedades de Neurocirugía.
De Colombia.
No,
Mundial.
World.
Ok, tal vez yo voy a contactar a ellos para ver. ¿Quién es el jefe de esto?
No recuerdo el nombre, el doctor fue presidente de la Sociedad Colombiana de Neurocirugía. Te voy a conseguir el nombre y los datos para que lo contacte.
Sí, dame, porque la gente conoce Neurosurgical TV ahora. Cuando contacto a ellos, ok. Es más fácil para televisar, especialmente de YouTube. Hay programas de Colombia cada semana. ¿Tú has visto?
De Ecuador, de Bolivia.
Sí, está creciendo ahora. Y tenemos Ecuador mañana, no mañana, Ecuador es, yo creo que es viernes esta semana.
Viernes.
Déjame ver. Sí, Okay. Oh, Dr. Goel. Okay.
Es
See,
la de Ecuador.
see, Llewellyn, see too. Llewellyn, you need a speaker. Atul Llewellyn, he's always ready to speak.
Yeah.
You know him, right, Llewellyn? You've probably seen him.
I know him very well. Yeah. Thanks, John. He's always willing to speak. Yeah.
No, he's always ready to present. If you need a speaker, just for future reference. Okay. Yeah, you know Salazar, right, Griselda?
Mhm.
Yeah, both. That's his son, right? It's Byron's his son of Jorge. And yeah, they seem pretty determined. Every week they're doing that now from Ecuador. Very organized. Okay, we're getting the last rush here. Llewellyn, are you originally from South Africa?
Yes, I'm part of an Indian contingent who arrived in South Africa about a century ago. So I'm third generation South African now, fourth actually.
Oh, so there's a large Indian presence in South Africa?
Yeah, so at some point it was the largest concentration of Indians outside of India.
Really?
I think the states may have passed us now, but we've got about 2.5, 3 million. Somewhere there.
I wasn't familiar with that.
Yeah, it's pretty solid.
It's not, yeah, geographically, it's not that far, really. I mean, it's far, but I mean, it's in the same. If you get in a boat and drift, you might end up in South Africa.
You might.
How you doing, Mohammed?
Hi, John.
I'd like
Hi,
you
Leon. How
How you
are
doing?
to, Mohammed, I'd like you to meet Griselda. She's a pediatric neurosurgeon from Mexico. And this is Mohammed. He's a neurosurgeon from Egypt. He helped put together this conference.
Hi. Hi, Ramesh. How are you? Good to see you.
Yeah, the world of pediatric
She's
neurosurgery. Yeah, there she is.
Yeah. So how many attendees we have?
Well,
The-
it's hard to say right now. We just have 10, but it'll end up probably around 25, 30 probably. Because a lot coming late.
Mhm.
Okay, 6 minutes we got. Yeah, send a blast out to your Facebook followers with the link.
Yes, I'm doing so.
Now's a good time for all people on the panel to help us promote this event and let people know what's happening. So everyone on the panel, just get your smartphone out and forward the link to your followers. Yeah, I've got to enlist, I got to put the panelists to work.
Okay, let's see if all our panelists have joined, John.
Okay.
So I see
Dr. El Fiki's here.
yeah, Muhammad Al-Fiqi is there. If the guy hasn't joined yet, wonder if I should just send him a message.
Daniel Bourbane, he's here. It always comes down to the wire. Griselda, you there?
¿Qué pasa?
Yeah, you can write this down. This is the Africa Pediatric Neurosurgery webinar series. Okay, and this talk today, the theme today is adjuncts and nuances in pediatric brain tumor surgery. You got that? Did you get that, Griselda? You get that?
Yeah.
Yeah, okay. It's just, you just read it from the banner if you have the banner there. And I'm not trying to make you nervous.
3 minutos.
2 minutos. Llewellyn, are your speakers here?
Not all. Just
Okay,
waiting for one to
we can wait a couple of minutes if we need to.
Yeah.
Or
I think some may still be late in joining, John,
yeah,
probably
that's
because
it,
of
that-
the time thing. Yeah.
okay, if you want to juggle the order, that's
Yeah,
fine.
no, we should be good for order. Our first 2 are here, I think.
Oh, okay.
Mo, you're gonna kick
Hi,
things
guys.
off, yeah, how you, Mood?
I'm good. How are you?
You slightly sort of flipped over the other way there, Mood, but yeah. There we go. That's it.
Hi, everybody.
How's that?
Welcome.
How are you?
Welcome.
Okay.
Oh, Mahmoud, I want you to meet Griselda. She's a pediatric neurosurgeon from Mexico.
Oh, hi.
She's the head of the organization in Mexico.
Great. Well, don't see the images. Let me see.
Yeah. Do you see, did you meet Mahmoud, Alma? Griselda? Oh,
I'm here.
Hello.
Hello. Nice to see you.
Oh, nice to see you. Hi. Good to meet you.
Thank you.
Whereabouts in Mexico? In the Mexico City?
Yes. Yes, I am in Mexico City.
All right. Only touched Mexico City on our way to Puerto Vallarta some time back when there was an IFNE meeting.
Oh, yeah, I was there.
Yeah?
all right. Small world.
Yeah. Small world. Yeah, we were wondering whether it was going to happen or not because of the hurricane, right?
Yes.
Yeah. So the hurricane hit 100 kilometers away from Puerto Vallarta, so we were okay.
Yes.
Okay, Griselda, you ready? I'll go 10 after I go 10, 9, 8, 7, 6, 5, 4, 1 after 1. Just take it away, okay?
Hi,
Okay.
everybody.
Okay, 10. Yeah, you ready, Llewellyn? You ready?
I'm good. Mo, you
Okay.
want to get started? Yeah, I think we're okay.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Go ahead, Griselda. Unmute, Griselda, please.
Hello, I'm Griselda Ramirez, pediatric neurosurgeon in Mexico City. Welcome to this new meeting about the neuro-oncology in pediatrics patients.
Okay.
Thanks so much, Griselda, and thanks to John for all the effort in putting the logistics together and distributing and doing all the sort of hard work really in getting the advertising out. And then I'd like to start off. So this, as a lot of you would know, is I think at number 6 or 7 in our series of pediatric neurosurgery webinars. We focused the last few just on pediatric brain tumors, and we've had some really distinguished speakers. So this week we're particularly privileged to have a lot of African speakers, and I'd like to start off then firstly by welcoming the president of CAANS, Mahmoud Qureshi. So Moody, welcome. We've also got a very senior neurosurgeon from from Cairo, Professor Mohammed El-Fiki, who I'll introduce personally as well. Professor Belouche, who unfortunately couldn't make it, but otherwise all our panelists are here. And like I said, we've got a great series going. Kicking off the series would be one of my co-hosts, actually, Professor Mohammed El-Beltagi, who's a pediatric neurosurgeon in Cairo, and I'll introduce him fully before his talk. And then Professor Anthony Fugaji, who's the head of pediatric neurosurgery at the Red Cross Children's Hospital in Cape Town, and I'll close off the sort of speaker panel at the end there. So maybe just before we kick things off, Moody, you want to just say a few words quickly?
Yes, if I may, Llewellyn and Mohammed, on behalf of CAANS, I really, once again, thank you so much for making the time and the effort to put together a pediatric webinar series, because we've been talking webinars all along for the whole period of the pandemic. And with 60% of our population being pediatric, it was unfair that we weren't covering that. So, and so far, it's really been an exciting series, and I look forward to listening to the excellent talks. And again, Tony, thanks for taking time. You're extremely busy, as is Mohammed and Llewellyn, and for you to make time for this webinar is awesome, really. Thank you so much. So on behalf of all the member societies of CAANS and all members of the Continental Association, we'd like to thank you and welcome you. And also thank you from Mexico for coming to join us to enhance the series. So over to you, Llewellyn and Mohammed. Thank you again.
So thanks, Moody. And just sort of out of respect for the kind of seniority and status of our speakers, we'll introduce them personally before they speak. So I'm going to start off. I'll introduce 2, and Mohammed will introduce the other 2. So Mohammed's one of our first speakers, but we're also privileged to have a very distinguished neurosurgeon from Cairo with us today as well. So I'm going to introduce him briefly as a panelist, Professor Mohammed El-Fiki, who's Professor of Neurosurgery at the Alexandria University, former head of neurosurgery at the Department of Neurosurgery at Alexandria University, and former president of the Egyptian Society of Neurosurgeons as well. Also editor-in-chief of the Egyptian Journal of Neurosurgery, and is the second delegate of the African Federation of Neurological Societies, the WFNS. So Professor El-Fiki, thanks for taking the time to join us, and welcome. If you want to say a few words, you're welcome to.
It's an honor to join, and it's an honor to support all African work, especially in pediatric neurosurgery. Thank you all. You're doing a great job.
Okay, thanks so much. Mohammed, you want to say anything? I'll start off with introducing you. I think that would be sensible.
Yeah.
But if you want to say something.
I just want to thank Professor El-Fiki for support and joining us. Of course, Moody and John for helping us in all this. Yeah. And we can start if you're ready.
Okay, great. And I'm just going to run through the program quickly. So kicking off our series of talks today will be Professor El-Beltagi, and then that'll be followed by Professor Fugaji, and then I'll close off the series of talks. And like I said, I think we'll introduce each of the speakers personally before they talk. Mohammed, is that your screen? I think it's probably sharing a bit more than you wanted to. Okay, so Professor El-Beltagi and I've been co-hosting the series for a while now. I think we're in our 6th rendition. So Professor El-Beltagi is Professor of Neurological Surgery. He's the head of the Department of Neurosurgery at the Children's Cancer Hospital in Egypt. He's done numerous fellowships at Boston Children's, Harvard University, Zurich, and Frankfurt. Is widely published and currently runs one of the busiest pediatric brain tumor programs really around. And he's a widely respected and very well established pediatric neurosurgeon. So Mohammed, it's a particular privilege for me to introduce you and ask you to start with your talk. Thanks.
Thank you, Lewin, for this introduction. And I will be talking about endoscopic assisted microsurgery, especially in pediatric brain tumors. So to start with, Hopp and Pernitsky in 1990 introduced the concept of endoscopic assisted surgery, in which a surgery is primarily led by the operative microscope in addition to endoscope, to have differentiating it from endoscopic controlled neurosurgery, in which the endoscope is utilized as the primary operative tool. In endoscopic assisted techniques, the medium for surgery and utilized are primarily microsurgical, while in purely endoscopic procedures, we have the medium for surgery is water and the tool utilized are transendoscopic. Yeah. So what is the benefit of using the microscopic surgery? You have a better operative field of vision, you have less brain retraction, better exposure through the better illumination, you have wider angles and the possibility to demonstrate structures from different angles and look in corners, besides being less invasive by reducing the approach size and retraction of the structures. That's when we have this using the endoscope. Okay, that's the endoscopes used. The scope, you can see here an angled scope. This is the tracker, and that's the 0 degree, the 3 degrees, and that's the holder where you can hold the endoscope fixed rigidly to the table. These are the instruments used in endoscopic assisted. As you can see, they are all angled scopes and angled also biballers and dissectors. As a background, there was a debate existing regarding what is the optimal strategy for managing brain tumors. The ideal surgical approach when you are dealing with pediatric brain tumors should give you access to all the tumor borders, and you have allow you maximal safe tumor excision and resection. Again, Pernitsky in 1998 have introduced this endoscopic assisted microsurgical procedures. And in 2007, Herwig published that endoscopic assisted microsurgery would provide you with the important ability to look at corners and behind the lesion in question. When you choose your approach in pediatric brain tumor, we have to have a safe entry, short trajectory, tumor access, and ability to assess all hidden corners, early access to tumoral blood supply, and ability to create cleavage planes, avoid injury to eloquent areas, and the plan to attack and component attack. With the transcranial microsurgical approach, it's very excellent in exploring most of the planes, chiasm, cranial nerves, and major vessels. All neurosurgeons are familiar with this approach, and they have a wide exposure with a confident hemostasis plus stereoscopic vision. However, there are still surgical microscopes cannot access blind or hidden corners, and there are some neural elements like the hypothalamus and some underneath of the chiasm and stuff, which could not be visualized during the microscopic surgery. And surgery of giant tumor with complex extensions sometimes mandate an accurate assessment of your field and the boundaries and relation. By combining both the microscope and the endoscope, we can get the maximum benefit of both and the minimum drawbacks of each, and simultaneous endoscopic microsurgical resection for brain tumors in children be a novel approach such challenging tumors. That's how you can handle the endoscope while doing microsurgery. Here, you can use your hand with the endoscope one hand and suction in the other hand, or you can use this fixation, which I showed, the rigid fixation, fixing the endoscope, and you can use both hands, or here you can use the assistant hand holding the endoscope for you, and you can use both hands. The theater is held or is organized where the surgeon stayed here and the assistants and the nurse, that endoscope is in the front corner like here, and you can use the microscope where you can look in the microscope and just have the endoscope parallel to the underlying pathologies that could be used and currently indication for this kind of approach. In general, aneurysm surgery, CP angles, tumor, intraparenchymal lesion like brainstem and cerebellum, intraventricular and skull-based tumors. In children, I use this a series of cases like the cranius and clival chordomas, CPA, pineal, lateral, and forced ventricular tumors. In case of a cranial surgery, enables me for a more detailed appreciation of the tumor relation to the undersurface of the chiasm, hypothalamus, and pituitary stalk. Also, residual is easily assessed by this endoscope, especially the 30 degrees. And even if you're going, the total excision is not possible, you can still leave a small residual by using an endoscope assistance. This is a 13-year-old male who have this craniopharyngioma. We approached it using a left pterional approach, as you can see here. Start using the microsurgical approach in removing the largest and the hardest part of the tumor that could be removed safely by microsurgical technique. And here I introduced the endoscope. That's the pituitary stalk, as you can see, hanging with a small residual underneath surrounding the stalk. But the endoscope, I can still remove this part, and you can see that's the membrane of Lilliquist, and then use both hands endoscopically assisted, removing all the residual hanging on the on the lower part of the pituitary stalk. You can all this by endoscope, and you can still check all the corners using your endoscope around before deciding to stop the surgery, to continue removing using either the microscope or the endoscope. That's using scope in case of a craniopharyngioma. That's the post-operative images. That's another again with tumor back to the pontine angle, and endoscopic assisted was very helpful to get all this part backward, and that's post-op images. Here in this special case, I did it microscopically, and the introduction of the endoscope dual part, as you can see underneath of the optic chiasm here, where the microscope couldn't show this part. And by the distance of the, I can still remove this hidden part in the under surface of the optic chiasm safely and dissection, removing it endoscopically. This is another case again with CP angle tumor going through an approach. I could manage to get all that back from one approach, all that back in the CP angle with one approach. This is endoscopic. You can do tumor residual and assessment of the membrane of Lilliquist. This is a small residual attached to Lilliquist membrane. That's the basal in the perforators. You can still see this mostly with the endoscope and safely removing. endoscopic assessment. In this case, this was a hard cranial. You can see its whole calcified. That's the perforatus. The third nerve, the optic nerve, through opticocarotid approach, getting with the endoscope. I just try to dislodge this calcification, make sure not attached to the undersurface, or it is attached to any of these perforators or vascular structures. This could be could be helped very carefully by the endoscope, as you can see, until dislodging this calcified. You can down and then use the microscope to remove it. Here, get it totally from the interoptic area. This is a 7-year-old male, again female, with this hard calcified part. I just want to highlight here that sometimes there is no space, dissecting carefully until creating spaces where the endoscope can be introduced between the planes you create in order to see the structures hidden behind and here I start dislodging this calcified part, as you see by the microscope. I just make it fast until getting it out using the microscope. And I just want to show you here how I put the endoscope. Here is the endoscope, how it looks under the microscope when I do from opticocarotid, then from interoptic. And that's how holding the endoscope by the diagonal approach. That's how I introduce it. And that's how it looked when checking it. When I in the optic, the pituitary stalk, that's the dorsum celli. That's after removing the calcified part of the cranium. And I can still check down to the basilar artery with the endoscope to make sure that there is no residue. That's again the stalk, and then you can go through both between them, and you can go to the opticocarotid looking for residuals. That's the immediate positive images. This is another of a huge cranium, just showing you an image how you can look through the right pterional approach back to the third ventricle with the graft in this huge tumor. So in case of a CP angle tumor, it gives you a good exposure to hidden corners and also a panoramic. It's an epidermoid, just going with the endoscope and then microscope to check with monitoring, and then going back down. Here is the 7th complex. The residual tumors endoscopically and simultaneously microscopically, working with both tumors and in such small area. Some imagine that finished, when you go again with the endoscope, you find small residuals attached to the cranial nerves and nerve, which was impossible to be seen by the microscope, regular microscope. And again, the endoscope, the acoustic meatus, you can go inside the acoustic meatus, as you can see, to check, because the epidermoid, you can see creep between the. This is another patient, 11 years, with trigeminal neuralgia, which presented to me with this very small axis going through CP angle, CP retromastoid, and then introduced a pediscope, which I use in pediatrics. Is this from Escolab? The division is not really nice with the normal regular scopes, but you can still go down through a very small craniotomy. Since it's also an epidermal, you can go to residuals endoscopically. You can see here it's not very clear vision when using these scopes, but it was very helpful in removing the rest of the residual tumor. That's the post-operative images. So what about a case of lateral purely vascular supply relations? You can have early control for the vascularity, and you can guide trajectory. Posterior third ventricular tumor, where I used the trocar of the endoscope, introduce it through a Kocher hole around the trocar of the endoscope. Then I introduced the endoscope first, going to the to the foramen of Monroe, and back you can see the tumor here, where I was inspecting only by the endoscope, and then I started coagulation and dissecting the tumor. You can see all this, and taking some biopsies. All this have been done by the endoscope, and then through cortisectomy, I got out the whole lesion from the microscope, and then checking back using the endoscope to make sure that there is no residue. That's the post-operative images. It showed to be a mature cystic teratoma. Here is case of forced ventricular tumors. You can also use with least cerebellar retraction, and you can achieve a total resection. This is one of the forced ventricular tumors. Of course, it's not mandatory, and sometimes it's helpful. I'm not using it regularly in all forced ventricular tumor, but you can go by the endoscope around the lesion. You can see these attachments to the peduncle. I can just go and go sharply dissecting and cutting it. I just create the planes and then go by the endoscope. You can see here attachment to the peduncle where it could be coagulated and sharply cut using the endoscope. Here, yeah, and then after clearing the whole forced ventricle and the brain stems, then at the end inspecting the aqueduct and the tumor bed, and that's the post-operative images. Another case of a pilomastrocytoma. Going with the endoscope, you can go down surrounding the to check attachment to the forced ventricle. You can dissect and go to the aqueduct, and at the end you can check with the endoscope for any blood bleeding or any residual. Just for the sake of the time, that's in case of ventricular tumor. This is one of a trigonal tumors which I approached again, create the plane first, then use the endo, start vascular supply pedicle at the beginning, and after clearing the pedicle and coagulating it, I start sometimes working with the microscope and sometimes with the endoscope. Once I've cleared the pedicle, the vascular pedicle, and checked all around, using endoscope simultaneously with the microscope, and then doing the whole tumor from the trigone, and then checking again for any bleeders or any small residual. That's the 2 years post-operative. It was a meningioma. In case of a choroid plexus papilloma also, we can use the endoscopic assisted. Of course, such a huge tumor where vascularity, this is a carcinoma with biopsy in somewhere else and refer to us where we have done this debulk, then introducing endoscope. Also, in case of small tumors in the foramen, you can introduce the endoscope and assess pedicle. This is another case. Here is a 6 months female patient with the headache, and MRI showed this third ventricular as consistent with choroid plexus papilloma. I did an ultrasound through a mini craniotomy. That's the tumor at the foramen of the row, and vascular duplex. I identified the pedicle to be in the beginning of the tumor this corner. Then I introduced the endoscope and I start coagulating the pedicle part of the tumor and attach it to the choroid plexus. Make it fast. And then after securing the coagulation, I start sharply cutting the pedicle, all this endoscopic and the mini craniotomy, and then coming out with the whole tumor together with the trocar of the together with the whole scope. And do third ventricle, and that's the post-operative images. So, what is the complication and the use of endoscopy during skull-based surgery may correlate with iatrogenic damage of nerves and vessels. Then there was a publication by Hari et al. Reported about the of facial nerve during inspection with the endoscope in one case of serous. We didn't have any of this. Actually, the risk of using the instruments, especially the 30 and the 45, the 70 angulated optic should be kept in mind. I never use a 70 degree or a 45. I just use a 30 degree, but working with a 0 degree. With angulated scopes, it's not always easy to know where the tip of the instrument is. You have to put in mind, have to well train this. A take-home message: the endoscopic assisted microsurgery of pediatric brain tumor is a promising friendly to implements microsurgery in the management of these complex lesions. Simultaneous and tandem endoscopic microscopic approach enables mechanism and subtotal resection of such tumor, especially in hidden corners. And the benefits of the ordinary endoscopy are added to the perception for safe resection and to improve outcome. So the main conclusion is that the discovery of additional information at the target is certainly the principal advantage of this tool. To see in the corner everything, but the discovery of a new thing, usually using the endoscope, you will find new. This is one of the recent 2021 publication in Neurosurgery Focus, which I just published in the benefits of endoscopic assisted microsurgery in the management of pediatric brain tumors. Thank you.
Okay, thanks, Mohammed. That was a really fantastic overview, and and clearly, as you pointed out in some of the previous discussions as well, your experience with these endoscopic assisted procedures is vast and growing. John, do we have any comments or questions on the chat?
Not to this point.
Okay, so perhaps I could, before I sort of open it up to one of our or some of our other panelists, Mohammed, ask you a question. Just two things. So some of the quality of the images from the endoscope seem to be quite different. Is that an endoscope specific thing? I know you said you use the pedoscope, but do you use, for instance, the OA Handy Pro, or which is your kind of workhorse, endoscope?
No, I use the pedoscope just in one case. Was very small approach, and the tumor was a prepontine. So I just, in this case, used the pedoscope. It was not. In general, I use a Storz scope, the 0 degree scope, and the 30 degree scope. That's the two scopes I'm using, and the image is quite good. the new SPICE camera and the 3D one. Did I answer
Okay.
your question?
Yes, no,
Hear
you
it
did.
well,
Thanks.
maybe?
No, thanks, Mohammed. Just on that note as well. So I think the value of endoscopic assistance really is underscored by, you know, how senior your assistant is. If you have a junior assistant with the endoscope, it could be an unmitigated disaster. So on that note, do you use any of these the holding instruments for the endoscope, or do you have a registrar trainee holding the scope for you?
No, I have one of my is already one, so I just keep him holding the endoscope for me. That's the most comfortable thing. But in case I don't, if I feel he's going to shake, because it's usually very risky if you're not well trained with handling the endoscope in such a big incision. So I use the regular fixators, like the handling of stores or Escola.
Yeah.
But
Yeah, no,
for injection, I prefer it with my own right hand and the suction in the left hand, if just inspecting. But if I'm going to or work, I prefer someone holding for me.
Okay. Thanks, Mohammed. I think that's fantastic. Let me see if there are any questions. There's a hand up. One of the panelists, John, do you know who that is? I can't see.
Okay, I don't see any so far.
I see a hand up there. I can't find it. Maybe I'll just scroll down and see if I can find it.
Okay,
This is me.
Mohammed Al-Fiki. Okay. Professor Al-Fiki, yeah, comment?
Yes. Well, that's a great work, Professor Bertaghi. In the good old days, we used to use a dental mirror before the introduction of the endoscopes. It was an essential instrument, usually, especially in craniopharyngioma, supracellular lesions, CP angle lesions, brainstem lesions. It helped a lot in looking behind the lesions and inspecting the vascular supply and the attachments of the lesions. And then we moved to using the endoscope for the same purpose. The addition was sometimes, as Professor Bertaghi mentioned, it's possible to use a fixed holder if you are going to do 5 to 10 minutes work without somebody jeopardizing the field. And you can use an assistant, of course, if he's well trained. The problem of crossing cranial nerves or vascular structures with the endoscope must be kept in mind all the time. And before you introduce any instrument, just start looking with the microscope along the path of the endoscope. Because the problem is when you move instruments outside of the visibility of the endoscope, you might hit structures crossing. So there is a golden rule that you do not cross blood vessels or nerves during your endoscopic manipulation.
Okay. Thanks.
May I just ask Mohammed something?
Go ahead, Modi. Yeah.
Excellent demonstration of various approaches for various tumors. And I'm sure the young neurosurgeons listening on the panel are looking at it with awe and wondering how they will get there and when they will do that. From a point of view of advice to our young neurosurgeons, what do you see as the milestones they need to gradually achieve before they get to the level that you are describing? Because when you first hold the endoscope, one's very excited. You then obviously want to do basic stuff. But what is your advice to our young neurosurgeons? What do you want to achieve? How many cases would you want to have done of a certain type before you move to the next and to the next before you come to the level? That's number one. And the discussion between an assistant holding the endoscope and using mechanized holders, whether manual or automated. I think in a training environment, my own personal view is that one should encourage the residents to be involved in holding that endoscope as much as possible, so that they get the feel at each stage of their development. So by the time they're doing the procedure on their own and you're under your supervision, they're more than comfortable in moving the endoscope in and out, are comfortable looking at the 0 degree, the 12 degree, the 30 degree, and the nuances that you very nicely discussed. What are your thoughts on that?
Yeah, thank you. Of course, to get to this level, it needs a learning curve. All they should be able to use scope for the regular techniques like the ETV and the endoscopic biopsies through the ventricle, nasal, by getting familiar with the endoscope. And in case of endoscopic assisted, I would suggest that they start by endoscopic inspection. When you are doing any kind of tumor and you have the space, you can hold the endoscope even with both hands and just go through the space and to inspect tumor bed or to inspect around the tumor. This is the safest without trying to use any tools, endoscopic tools or section. By holding the endoscope in giving the assistant the hand, of course, this is, as you mentioned, give them the trust to do this later and get them a high learning curve, and I totally agree with you. And in the beginning, they can get familiar by using the endoscope with inspection. Then we can let them hold the endoscope with both hands through the approach at the office of the craniotomy without going deeper in the beginning until they feel more comfortable to go and navigate inside the bed, inside the cavity. So that's, I totally agree with it needs a learning curve and have to be familiar with the endoscope, regular endoscopic surgery, and using it for inspection. I did that for many cases in the beginning, just inspecting. I remember once I just presented one presentation showing that I just inspecting, and then I said I don't have the courage yet to go with the tools through a craniotomy and looking up into the endoscopic screen and use my hands in a big craniotomy, except when I feel more comfortable and trusted.
Okay. Thanks, Modi. Those are incredibly important points. You know, there's a very steep learning curve, and I think it needs to be tiered. In fact, I'd probably add one little caveat to that, that there should be training on a simulation model as well. There are lots of those available now, and we've run some of those courses. So if there's no other comments, we're going to move on to our next speaker. Mohammed, I'm going to hand over to you to introduce Professor Figaji, who's our next speaker.
Yeah. So our next speaker is Professor Tony Figaji is a professor and head of the pediatric neurosurgery unit at the Red Cross War Memorial Children's Hospital in Cape Town. Professor Figaji is a prolific author and leading academic neurosurgeon. He has a particular interest in monitoring the brain, both intraoperatively and in critical care for brain injuries, both traumatic and infectious. He has served on the executive board of numerous international organizations, including the INTS, ISPN, ISI, Global Neurosurgery. He is currently invited at the International Neurosurgery meeting and serves on several advisory committees. Tony is going to speak about intraoperative neurophysiology in pediatric brain tumor. Yes, please, Tony.
Thanks, Mohammed. Can everyone hear me?
Yep, can hear you fine, Tony. Go ahead.
Fantastic. Well, thank you for the invitation. I've been asked to speak about intraoperative neurophysiology and the way that I use it in pediatric brain tumors. So the first question, of course, is why use intraoperative neurophysiology at all? So the first and perhaps the most obvious concept is to try to increase the safety of operations that have high risk. So typically these would be operations near eloquent areas. So near the sensory motor strip, the internal capsule in the brainstem, craniocervical junction, spinal cord, and cauda equina. So the idea is to try to get an early warning sign that tells you you're doing something to damage the brain, the brain stem, or the spinal cord, or the spinal nerves before that damage is permanent, so that you can react to that, reverse what you're doing, and try to avoid a permanent deficit. So in most people's mind, they think about intraoperative neurophysiology primarily and sometimes solely for the idea of just trying to avoid injury to a patient. But there's a flip side, of course, of intraoperative neurophysiology, in that if you're using it as a tool to prevent prevent injury, but also to be aware of cognizant of brainstem function and spinal cord function that is still normal, then what one can do is try to use intraoperative neurophysiology to actually increase the extent of the resection and be more aggressive about taking out the tumor. So one of the problems that we have as surgeons very often is we don't know where to stop in resecting a pathology, and our anxiety always is, if I take this last little bit of tumor out, of course it will improve patient survival, the likelihood of cure, but am I going to cause a permanent injury to the patient? And of course, if you have decent monitoring and you know what you're doing and that monitoring is normal, then you have that increased confidence of extending the resection to at least a near total, or at best a complete resection. And then it's about continuous learning. Intraoperative neurophysiology is not going to make a difficult operation easy. It's not going to make a risky operation safe. And intraoperative events will occur. And one of the difficulties that we have as surgeons sometimes is we have a patient who develops a postoperative deficit, but we are unaware about exactly where that problem arose in surgery. And so you can't develop continuous learning because you don't know which of your intraoperative maneuvers caused that deficit. So one of the things about intraoperative neurophysiology that I've come to appreciate is teaching me about which are the intraoperative maneuvers that I've been doing for many years are the ones that potentially cause injury. There are a couple of caveats that I think one should mention. One is that it's an adjunct. It's only an adjunct. It's no more than an adjunct, and it's no less. So it's not going to make a good surgeon out of a bad surgeon. It's not going to make a great surgeon from a good surgeon. It's not going to enable you to do something that you wouldn't be able to do without surgical experience and wisdom. So you can't, just by using intraoperative neurophysiology, go take out a brainstem tumor if you haven't developed the surgical skills. And certainly when I look back on my career, I'm very, very aware of how intraoperative neurophysiology has helped me, but it hasn't enabled me to do things that I wouldn't have been able to do. It just helped me to do it safer and at least a more complete job. So intraoperative neurophysiology is in no way a substitute for surgical skill and good decision-making during surgery. It's just an adjunct. And then the second thing, and this is really important, I learned this from Francesco Sala, that bad monitoring is worse than no monitoring at all. And there's really no place for trying to do intraoperative neurophysiology monitoring if you don't know what you're doing. And there are major consequences to getting the calls wrong. So if you have a neurophysiologist or you're doing the monitoring and you say that the signals are present, but you're only looking at noise, then the surgeon or you are going to make a decision based on that, and you're going to harm the patient. And the flip side of that is if you've lost signals, but you've lost signals because of a technical reason, and you believe that that's a physiological reason, something that you've done intraoperatively, then again, you're going to make a bad call on the basis of that. And in that context, bad monitoring is worse for the patient, probably, than no monitoring at all. And so there are lots of things that you can read about intraoperative neurophysiology and how it helps us. With resections, they tend to cluster around the publications for low-grade glioma, usually hemispherical, and for brainstem and spinal cord tumors. Those tend to be the oncology-related applications for intraoperative neurophysiology that are commonest. Francesco Sala probably published this as the landmark article for intraoperative neurophysiology in spinal cord tumors, but things, of course, have moved on considerably since then. Just a caveat, though, about reading about intraoperative neurophysiology is that there are several publications out there that are also, from my point of view, unhelpful. So there are case control studies, for instance, where they did intraoperative neurophysiology in some patients and no intraoperative neurophysiology in other patients and didn't find a difference. And you really can't do any studies. You can't do studies like that because you can't control for the reasons why some patients had intraoperative neurophysiology and some patients didn't. And obviously, the risk profile for patients in which you use IOM typically tends to be a lot higher. So unless you randomize patients to intraoperative neurophysiology and you're never going to get a complete answer. And I don't think we'll ever have a randomized trial. But of people who tend to push the boundaries, and this is across the world, whether for glioma surgery, hemispherical tumors, for brainstem tumors and spinal cord tumors, it's a standard method for trying to increase safety and increase the extent of resection. And this is the reason, of course, we're typically operating on areas of the brain, like a brainstem, that are compact, they're small, and they've got a huge amount of function that doesn't announce itself. So it's not like you see in the textbooks with all the structures of the brainstem or the spinal cord or the sensory motor strip that are easily identified and color-coded. We very often are in areas where we just don't know where the functional tissue is. And that's the purpose of using monitoring and mapping. So just to give you a very broad overview, there's monitoring and then there's mapping. So for monitoring, there are several techniques that we use. So one would be for the motor system. So for the motor system, we typically stimulate the motor cortex, and we'll either stimulate that transcranial, so electrodes placed in the scalp over the motor cortex, or, and much more rare, we will stimulate that extradurally or subdurally. And then the stimulus is over the motor strip, and the receiving channel is generally in electrodes that are placed in muscle groups. And the muscle groups that you use depends on the pathology that you're treating, or the anatomy rather, that you're treating. So there will be EMGs, motor evoked potentials, and something called the D wave, which is from an electrode that you put in the spinal extradural space, usually for spinal cord tumors, but you can also use it for craniocervical junction tumors or posterior fossa tumors, where you've exposed the upper part of the spine and you can get a D wave electrode into the epidural space. And then the sensory system. So here the stimulus is peripheral. So typically it's either the tibial nerve or the median nerve. You place electrodes to stimulate the tibial and the median nerve, and your receiving channel is then on the surface of the brain or the surface of the scalp, with electrodes that are placed along the sensory strip. And then you can monitor EEG as well to detect intraoperative seizures, particularly when you're doing cortical stimulation. And then mapping. So monitoring is continuous or semi-continuous during the operation. The idea of mapping is to try to find a safe place to enter in aliquot cortex. So typically it's either cortical, or as you progressing, resecting at the tumor, trying to find out how close you're getting to the internal capsule. For example, using subcortical mapping, you can map out the brainstem, both the cerebral peduncles ventrally, as well as the floor of the fourth ventricle, spinal cord, and spinal nerves. Typically, you start with the equipment. At our hospital, we have a system called Cadwell, called the Cadwell Cascade, but there are many other systems. So Medtronic makes a very good system that many people use. In Europe, Inamed is a large company that many very good neurophysiologists use as well. So there are several companies. Those are the three most popular ones from my point of view. It's important that you have a good operating theatre set up. So the neurophysiologist has to have line of sight with the surgeon, because communication between the neurophysiologist and the surgeon is key to achieving the best possible outcomes. It is helpful, of course, if the surgeon has a very decent understanding of intraoperative neurophysiology. It's helpful also, like we have the system here that is displayed on one of our panels, so we can see exactly what the neurophysiologist is doing. And there has to be this constant dialogue throughout the operation, particularly at parts of the operation that are at highest risk of causing injury. So these are the transcranial dermal electrodes. So these are little corkscrews, and we typically put corkscrews along the motor strip. And exactly where you put it on the motor strip depends on what you're trying to monitor. What's your kind of main focus? If you are mainly focused on the legs, they're going to be very medially placed. Arms are going to be a little bit more laterally placed. If you want both, you find the median point in between. If you're looking for corticobulbars, then you place them a little bit more laterally. For sensory, the sensory channels, they will be slightly behind the motor strip in something called C3 and C4 prime. And we typically have 4 electrodes to create four channels for. So C3, C4, CZ, and FBZ. So those are the sensory channels that pick up the somatosensory potentials from the tibial and the median nerve. You have to very often position patients prone if you're going to operate on the brainstem, for example. And one of the tricks is to be able to put these electrodes and keep them in. So the electrodes in the muscle groups of the face, those are generally not too difficult. It gets a little bit trickier when you use hook electrodes for placement in the tongue and the soft palate. And those I'll show you in a moment. Those are very, very fine electrodes, and you got to strap them down really well, because when you prone a patient, it's very easy for these to come out. And even if they come out slightly, it increases the impedance in the system and you lose your signal. So these are the hook wire electrodes. It's a needle. You don't leave the needle in, you just leave the wire in. And the idea is to put it in the soft palate. So we put 2 of these electrodes bilaterally in the soft palate, 2 on each side, because they create a channel. So you're stimulating over the motor cortex, corticobulbar, and that's your receiver channel. And then we put it in the muscle of the tongue as well on both sides for hypoglossal mapping and monitoring. And so it's quite nice to be able to do that with a child who is intubated nasally. They don't have to be intubated nasally, but when they intubated orally, you can imagine there's not a lot of real estate there, real estate space. You got to find a way to secure the tube and then move the tube off to the left or the right while you're putting in electrodes on the opposite side. And then you've got to strap everything down, so you can see how easily those would come out. And then just the last little bit while we're looking at the oral area is that they always need to have a bite guard in. It doesn't matter what it is, we just take a little bit of rolled gauze, and so we put it between the teeth, because when you stimulate the motor cortex, you're typically using high voltage. And in young children, it's not too bad because their muscle bulk is a lot less than adults. Adults can jump quite a lot when you stimulate their motor cortex. But in children, because they've got a relatively unmyelinated white matter, we typically tend to increase the voltage quite high. So the different systems are either current-based or voltage-based. Ours is voltage-based. And sometimes you have to turn up the volts to 500-600 volts to get a decent signal. Monitoring in young children is much more difficult than older children. Older children is more difficult than adults. And it depends on whether they have pathology as well. So you can have an adult. Typical normal adult monitoring is generally very easy. But of course, if you have pathology that is compressing motor pathways, then it can be particularly difficult to get a signal if patients have a neurological deficit. And then we put this electrode around the endotracheal tube as well. So these are somatosensory potentials. As I said, they come from the tibial nerve. So we put 2 electrodes and the stimulations between the 2 electrodes in the at the medial malleolus, just behind it, to stimulate the posterior tibial nerve, and then the median nerve, again, is quite easy because the anatomy is quite well known. And this is typically what you get. This is time duration, so somatosensory potentials, you can just keep running. And what we look for in somatosensory potentials when they run into trouble is 2 things. One is that the amplitude of the signal may diminish. And the second thing is that the latency may increase. So you may have retained your amplitude, but it takes longer for the signal to get to the somatosensory cortex. And when we make a call about whether there's a problem or not, it's about whether both the amplitude and the latency have changed based on certain thresholds that we set preoperatively. These are motor evoked potentials. Again, the motor groups that you are interested in depends on where you're operating and what you're likely going to cause damage to. The D-wave electrode and the D-wave signal, again, as I said earlier, is a spinal one. And then cortical bulbas. Cortical bulbas are quite difficult. I told you about the soft palate and the tongue and the electrode that we wrap around the endotracheal tube that sits at the vocal cords. The oculomotor nerves are very difficult to do. You can do something called near field potentials, which are just close to the interocular nerves, but the better way to do it would be to have an ophthalmologist give you a hand and directly visualize and place those fine hook wire electrodes in the actual extraocular muscle. Brainstem auditory evoked potentials are not always useful, so we do them only in restricted cases. Typically, that would be in the CP angle as an example. That's what a typical brainstem auditory evoked potential looks like. The different peaks correspond to the different anatomical sources of the signal. And so this is what typical motor evoked potentials would look like. We do a baseline, and then keeping everything constant, we try to keep everything that would affect the amplitude or latency of signals, particularly the somatosensory signals, relatively constant. So you want to keep a constant anesthetic, you want to keep the temperature relatively constant, you want to keep the blood pressure relatively constant, because all of those are factors that can influence the magnitude or the amplitude and the latency of signals, particularly the somatosensory ones. We run patients on total intravenous anesthesia because inhalants tend to drop the somatosensory potentials quite a bit. The motor evoked potentials tend to be a little bit more robust, but we run them on propofol. And so here's the baseline. This is left and right. This is hand. These are 3 channels from legs. So there's a baseline and then a current one. And you can see on the next slide, here's the baseline. And you can see the hands are still there and they're still robust, but the leg has dropped out completely on the left. So there's the quad on the left. Here's the tibant. Here's the juices hallucis, completely gone. On the right, it's substantially diminished compared to what it was. Very, very small. So clearly something's changed there. And when something's changed, you've got to go through the process of figuring out what's happened. And there's a troubleshooting process. You have a strategy for what happens. And the question is it a technical problem? Is it an anesthetic problem? Or is it a real physiological problem? Very often you have controls, like this is a physiological problem. It's not a technical problem. It's not anesthetic because you've got controls here in the hands of both sides. And those are still completely robust. And so when something like this happens, you have to identify what was the precipitating event that led to it and try to stop what you're doing. And the idea is if you've got a retractor in there, you're pulling a little bit hard on the retractor, you may be causing a little bit of ischemia. You release the pressure, you get the blood pressure up, make sure the temperature is normal, you irrigate and you wait for those signals to come back. If they come back, you proceed. If they don't come back, then you've got to make a judgment decision about whether the whether the interests for the patient are better off proceeding or stopping at that point. So that's monitoring. Mapping is trying to find a way to get into structures, the eloquent cortex, the sensory motor strip, or the brainstem, or the spinal cord. As an example, the most common application probably is the floor of the fourth ventricle. Floor of the fourth ventricle looks great in diagrams where everything's very well labeled. Doesn't look like that under the operating microscope. Very often you can see some of the anatomy of the floor of the fourth ventricle, but very often you can't because the anatomy is distorted by a tumor that's in the pons or in the medulla. So the idea is to try to find a safe entry zone. So this is one of my patients operated on many years ago with the fourth ventricular ependymoma, took it out and it recurred in the brainstem. So the question was, where do we go in? This is reverse. Here's the aqueduct. Here's the floor of the fourth ventricle. Here's the bulge of the tumor. And the question is, where's a good place to go? It's above the stria medullaris. It goes a little bit under it as well. And so the idea is, let me just skip along a little bit here, is to use, we use a bipolar electrode. So it's either with these two prongs like this one has, or something called a concentric bipolar. Try to map out the seventh nerve first, because that's generally the easiest, and then try to map out the lower cranial nerves as well. Keeping in mind that you can only map out the motor pathways, you can't map out the sensory pathways. Find a safe place or a safer place to enter, and then start the resection. And then while you're in there, again, bring in the bipolar or concentric electrode to find out how close you're getting to critical pathways, and then continuing to take the rest of the tumor out. You can do that same mapping on the cerebral peduncle. So this is a kid with a cavernoma in the midbrain. Shows a transtemporal, transventricular, transcoroidal approach to get to the midbrain, and then the question is, where do you go? The idea is to try to map out where the cerebral peduncle is if you can, and then go posterior to that. Taken out. Similarly with the tectum, also once you've gotten into the tumor, there's nothing that you can map on the surface. You can't map out the fourth nerve because it's very difficult to monitor. Some people can monitor it. I haven't been able to do that. But once you're in the tumor, then mapping can help try to determine how close you are to the cerebral peduncle tracts. Again, just the same principle. Tumor in the pons is one of the older ones, but it's the same principle. This is a concentric bipolar I'm using here, trying to map out the floor of the fourth ventricle where the anatomy is really not recognizable anymore. Starting tumor dissection, and then progressively using the concentric bipolar while you're in the tumor cavity, trying to determine how close you're getting to the surface of the tumor. These are more or less all the same things. You have to be very careful about the medulla because there are some things that you can't monitor. I said that is only for motor pathways. You can't map the sensory pathways, and of course you can't map respiratory center and cardiovascular control. But again, with judicious application, this is a ependymoma, again, another ependymoma that recurred. And typically when you're operating on these patients, so this is a patient that I operated on many years ago, and you can see everything scarred. You can't really recognize normal anatomy. And when you know that, that you're in the medulla in particular, you really don't want to get that wrong. And a little bit of orientation using mapping can again help you orientate and be a little bit more aggressive in taking the tumor out. And then lastly, craniocervical junction. We won't go into spinal tumors for in this talk, but craniocervical, high craniocervical junction tumors, you really don't want to get that wrong. It's very, very little space. It's a small, compact area. You get it right, you take it out, take the tumor out, and one of the most satisfying things about removing tumors in children, of course, is that many of them are completely benign tumors. You can take out the whole tumor, you cure the patient. But if you get this wrong at the craniocervical junction, not only don't you cure the patient, you leave them ventilated dependent, which is a terrible outcome, particularly for a benign tumor. This is just craniocervical junction. I don't think I need to show the whole picture. I think you get the idea. I don't usually use it for cerebellar tumors. The vast majority of cerebellar tumors one can take out without intraoperative neurophysiology. Sometimes when they encroach on the brainstem, like that medulloblastoma or this ependymoma, sometimes they're useful. Sometimes when they go into the ependymomas, when they invade the caudal medulla, sometimes it's useful as well. And then finally, with hemispherical motor mapping, a little trickier, well, actually a lot trickier in children than in adults. You can't map language passively, so wave craniotomy is best, but in young children, it's usually not possible. You can do direct cortical or subcortical stimulation with monopolar or bipolar. Again, a little bit more difficult than in adults. If you really know what you're doing, and my colleague Nick has done very well with this, you can put strip electrodes or grid electrodes and use an epilepsy-based approach to try to map out where the motor strip is. So this is an example of an awake craniotomy, just really difficult to do in young children. This was one of Nico's patients, and got a neuropsychologist at the bedside, testing language and movement. And then lastly, as I said, you can put these strip electrodes on, and this was for an epilepsy operation, one of Nico's patients of last week. Strip electrodes on, send the patient back to the ward, record the seizures, but you can also use these channels not only as receiver channels, but as stimulating channels as well. And then finally, subcortical mapping. You can get into the tumor, okay, but you're wondering how close are you to the internal capsule. And so that's much more appropriate for glioma surgery in adults. Okay, so how do you start? Well, it's not easy. We had lots of difficulty starting. I think the key thing is to get trained first and foremost, relying on colleagues who are experts in the field. The International Society for Intraoperative Neurophysiology has got great resources. Getting the equipment and consumables is very often the easier part. You have to start slowly, progress from easy cases to more difficult cases. And then I think in the long run, one really wants to enlist the assistance of the neurophysiologist. You don't necessarily need them to start, but if you're going to make a sustainable and high quality program, then it's very useful. And I'll speak a little bit about my experience if you want, if there are some people who've got some questions about how we exactly went about it, because when we started, there wasn't IOM wasn't available in our country at all, and I suspect that's probably true for many parts of Africa. I'll stop there. If you have any questions, happy to take them. If you don't mind, I'm just going to get a charger for my laptop that seems to be dying. But in the meantime, maybe Llewellyn, Mohammed, you can tell me if you have any questions.
Okay, Mohammed, you want to make some comments, or shall I go?
Okay. I just want to comment that nowadays you can do an intraoperative and do intramedullary tumors without neurophysiologic monitoring, and it is easy to dissect and remove ependymomas and low-grade gliomas in the medullary region. So I think it's impossible to do it without intraoperative monitoring. So, nice presentation. Thanks for illustrative presentation.
Okay, thanks, Mohammed. John, do we have any questions? I mean, I've got some questions and comments, but maybe we could ask some of the attendees or panelists if there are any, John.
As of yet, I don't see any comments so far.
Okay, so maybe I'll sort of bounce it between our panelists. Moody, any comments?
Yes, thanks, Tony. That was a superb expose of neuromonitoring from everywhere, from the cortex right down to the brainstem and to the nerves. I think brilliantly given, and as always, very eloquently described. In terms of the glioma surgery for cortical lesions, obviously in the adults, most of the folks around some centers in Africa are beginning to go into awake craniotomies. And what's the youngest pediatric case that you feel you've done with awake? I mean, you showed the one that Nico was doing, and that's one element of it. And I know this is more of a philosophical question, but what's the merit in having a well educated or understanding parent be with the child during that procedure? I know that's sort of outside the box thinking. Not many would want to do that, but I wonder whether that could move the envelope for a very anxious child who's just about ready to have an awake, but might be too anxious, and having the parent there. I'm just throwing that out just for your thoughts, because you obviously are the leading guy on the continent for peds, along with people like Mohammed. So what are your thoughts on that?
Yeah, I think it's just enormously difficult. I think it's difficult wherever you are in the world. I think it's a great idea to get a parent in there. But you got to select the parent also very carefully, because I mean, we take it for granted, but it's a wild environment, right? I wouldn't underestimate how enormously stressful it is. I mean, we wouldn't be able to imagine the idea of having your head opened and being counseled preoperatively that you're going to be woken up, and then having the anesthetic on board in such an abnormal environment, and then you're woken up. So adults that I've spoken to have really struggled with it. It's really, really difficult. So one can only imagine how difficult it is for a child. The youngest we've done, and we really don't do them frequently. I think it was 10 maybe, just before 10, maybe 9.5. But it was an exceptionally mature kid.
Yeah, I would imagine 10 is really moving the envelope, isn't it?
10 is very difficult. I know Francesco Sala and a few other people have got a cohort of patients that they've done around that age. But I do think that would be the exception. Awake craniotomy for adults is a much easier prospect. Not easy, but easier. And I think particularly from an African perspective, if I may, people often say, hey, you know, we don't have this equipment, and more important than that, we don't have the consumables. But even more important than that, we don't have the training. And what can we do to start along that road? And probably cortical mapping is the best thing that we can do in a limited resources setting, because ultimately it doesn't depend on a huge amount of training, and it doesn't depend on a huge amount of consumables. And the outlay for an ogive stimulator is generally quite reasonable. And if you've got a very good nursing and anesthetic setup, it's something that can be done with limited resources and is really, really helpful, particularly for glioma surgery.
Absolutely. Great, thanks. Thank you.
Yeah, thanks, Moody. Professor Alfiki, any comments? You've had some experience with this area as well.
Ali, it's a great presentation. My question regards, is it different to monitor a child or a grown-up? Are the values different? That makes you change your minds, that makes you stop? Or it's the comparison between right and left as we all do? Is it hard? Is it a smaller gadget or the same?
Yeah, so the settings are generally quite different. As a rule of thumb, it's the younger the patient is, the more difficult it is. So infants, children under the age of a year, again, largely because of unmyelinated fibers, it takes a much larger stimulus to get a decent signal. So typically we would use on a cascade system that's voltage dependent, we'd use 500-600 volts sometimes to try to get a decent signal. Whereas in a typical adult, you could get a signal from 150, 200 volts. So as a general rule, the younger they are, the more difficult it is. But as you said, you use every trick in the book and with comparisons as well. So you left and right, if you're operating on thoracic or cord equina, having controls in the hands, all those things are useful. As a general rule, you can get decent signals in children. And, you know, for our tethered cords, typically we'd operate between 6 and 9 months of age anyway, so that's standard. The somatosensory potentials are a bit more challenging in those patients because it's dorsal dysraphism. The motor potentials are generally quite stable. But then when you have a young child with a neurological deficit, those are the particularly difficult ones.
Thank you.
And Tony, how comfortable are you with these specialized endotracheal tubes that have got the monitoring facility on them? Are they something that that you rely on regularly, or it's always giving you a kind of false sense of comfort? Because, as you say, once you're positioning the patient, the tube's moved a few centimeters or a few millimeters, and you don't know what you're monitoring. So how comfortable are you when you're doing that with these kind of tubes?
Yeah, so I think the indication for using them almost defines the fact that it's not going to be a comfortable day anyway. So I think the specificity is a little bit better than the sensitivity. So if I use them and I get a decent signal, then great, then I'm comfortable. But my chances of getting a different signal, i.e. the sensitivity, that's not great. So that's a little bit hit and miss. And when you miss, it's not always evident that it's a technical problem or it's a problem because of the neurological deficit. But those endotracheal electrodes are a little bit hit and miss. And it's not that I'm so uncomfortable about it. It's just for me, it's a little bit unpredictable.
Right.
If I get a decent signal, then I'm comfortable with it. And I think the key thing from a person doing the neurophysiological monitoring is to be able to determine what is signal and what's noise. So the worst case scenario is when you're just getting a lot of noise that typically you would have from one of those endotracheal tubes or those fine hook wire electrodes, because the impedance is so high. It's easy to mistake noise for signal. But the trick is that noise varies over time, and you can look at the noise in your system, because all the instruments that you have in your operating environment all come through at 50 and 60 hertz. So there's a huge amount of noise, but the key thing about a signal is it's always at a predictable latency. So whether it's 15, 20 milliseconds, the signal is always there. It just doesn't vary. And when you apply that principle and you've identified the signal, then I'm comfortable. Only problem is I can't always get the signal.
Right. And if I may, Llewellyn, just one final one. Now that we have Tony there, we can kind of squeeze as much out as possible. What's your when the signal goes, you're operating and the signal goes and you don't know whether it's physiological and then you think it is physiological. What's your first reaction to kind of try and see whether that signal will come back? A warm saline, increase the oxygenation. What's your first reaction?
I mean, the first reaction, as you said, is to presume that you've caused the problem. And then whatever you're doing first, so that's the first thing, stop whatever you're doing. And then troubleshoot to make sure that it's a physiological problem. So we go through, did the electrode pull out? Or was there a change in the anesthetic? Did the blood pressure drop? Is there some electrical problem with the machine? Is there a problem with the computer? So you go through those troubleshooting maneuvers, but you almost anticipate that you may run into some technical problems. So you always have some controls. Like I showed you in that example, if your signals drop out on the left, but they're present on the right, then there's probably not a technical problem unless you've hooked your left sides only into one pod or some technical things like that. But there are ways of setting it up so that you can very quickly identify that it's not a technical problem, it's a physiological one. And then if you've excluded any technical problems and you believe it's physiological, then as you said, you stop what you're doing, you make sure that you release all your retractors, if you've got any fixed retractors. That's one of the things that we've learned over time, that fixed retraction is just generally a bad idea. So we become very concerned. We almost never use fixed retraction anymore. But if you've got a fixed retractor in there, take it out, make sure that the brain or spinal cord gets perfused again. Make sure that you get the temperature up and irrigate with some warm saline because the signals may just be irritable. Then get the blood pressure up and try to restore perfusion. And if you've done that, as I said, and the signals come back, great, you proceed, but you proceed with caution because you know that tissue is on the edge. If they don't come back, then you need to make a call.
Great thoughts.
Thanks, Mohammed. So I've got a couple of questions. I see there's an Uday Gupta who wants to ask a question, so maybe go for it.
Hello, am I audible?
Yes.
Audible, sir? Am I audible, sir?
Yes, you are audible.
Yeah,
sir.
I heard that keeping the family of the children, I think the mother of the child while operating during an awake rhinopathy of a small child helps to calm the child. Would you support this inside the OT or in an awake rhinopathy in the children? If the patient's family, mother or father is there, he tends to cooperate better.
Sure, I agree.
Yeah, it was a comment. I think it was helpful.
Yeah, I was asking because I didn't have any experience with that. I mean, we've done them for adults, but you just wonder whether we oftentimes bring the mum into the OR for the anesthetic part of it. Once the child is under anesthesia, they move out. But I just wonder whether that can be pushed. So that's the reason I was asking. I don't know if I have any experience with that. I was wondering whether anybody would consider it.
Yeah, look, I mean, we don't have much experience at all. And the cases that we've done have tended to be with Nika in terms of epilepsy resections. And you're getting epilepsy resections, dominant hemisphere, close to Broca's area, close to sensory motor. Then that risk becomes quite high. And so just maybe one other comment is that, so one of the other adjuncts that we often use, preoperative imaging with DTI, trying to figure out where the, and functional MRI, they don't always correlate with the intraoperative neurophysiology, because the one is anatomical tract and the other one is functional. And most of the people that I've spoken to over the years have said that when there's a discrepancy between the imaging, the functional imaging, the DTI, and the intraoperative neurophysiology, then believe the intraoperative neurophysiology.
Okay, Noel, there's a couple of questions on the board there. You want to ask them?
I'm going to just run through a few because of time, just to sort of capture all of these.
I don't want to hog your time.
No, Tony. I think it's quite important. So I'll keep the questions short. Maybe just keep the
Okay.
answers.
I'll
But I
keep
mean, like
on.
you've pointed out, the indications for weight craniotomy in kids is pretty rare. So that's.
Yeah,
But like you pointed out, Tony, so bad monitoring, like you say, is often worse than no monitoring. And I mean, my perspective on that is that communication and competency probably sum up the kind of basic tenet of your physiologist. What would you say is the minimum training that a BTech student or a neurophysiologist should have before you would say they're competent to monitor a kid you're operating on?
Well, Llewellyn, that's a tough one. I don't know if there's a clear answer, and it might be one of those things based that each center has to define for themselves. But I thought I just have to add our good friend Jim Goodrich, bless his dearly departed soul. One of his favorite sayings was, "A fool with a tool is still a fool." And it really, really is important. I would say, ideally for me, I'd feel comfortable with the neurophysiologist who's at least had a year of training, supervised training with intraoperative neurophysiology. I know in our country, and I'm sure many countries in Africa, that's not done. It might not be possible. But I think if you had to ask me for what would be an optimal benchmark, I would say at least a year of supervised training.
Okay, I mean that sounds fair. And having sort of driven this yourself and really invested, I know how much time you've invested into this, particularly in a medical legal environment like ours, just to mitigate risk, people find having somebody monitoring your operation is great, just to in theory mitigate the risk. But in some ways, I think that probably makes the monitoring less reliable and less, guys don't understand what the communication pathway is. I mean, do you agree with that? And it's a philosophical question, I know, but I think it needs to be done properly or not. Yeah.
I think in the States as well, there are lots of spine surgeries that get monitored that probably don't need monitoring, but they do it for medical legal concerns, and they pay no attention to the neurophysiologist at all. They just want somebody in there that they can tick a box. And I think that's just really, really bad. And I think it's probably puts patients at higher risk. And the worst thing is to have somebody there and you don't have those communication channels that you were talking about.
Yeah. Okay, Tony, I'm going to read you one question and I'm going to select here. So somebody has asked, how would you handle seizures during mapping in very young children? Do you use similar methods in adults of, ice cold saline?
Yeah, that's exactly what it is. Nothing special. Obviously, you need to make sure that the patients are still on the anticonvulsants preoperatively. But whenever you're going to, especially with the ogimin stimulator, much higher risk with that than with monopolar mapping, always have cold saline by the bedside. And then preferably, if it's possible, have a subdural strip to pick up subclinical seizures.
Yeah.
I mean, that might be a nice to have. I mean, most of the seizures are fairly obvious because of the hemodynamic change or the actual physical manifestation.
Okay, thanks, Tony, for a magnificent talk and eloquent as always.
Thanks so much for the invitation.
Okay, Mohammed, I'm going to hand over to you. I'm going to get the talk ready and try and make up for some time.
Okay, Professor Al-Fikri.
Okay. I'm happy to present the rising star in Africa, Professor Llewellyn Badayashi, who is the professor and head of the Department of Neurosurgery, University of Pretoria, is a chief specialist pediatric neurosurgeon at Steve Biko Academic Hospital, and he has won a Hamilton Mackay Scholar. Of course, he will give us an extremely interesting presentation as usual. Please.
Thanks so much, Professor Al-Fikri. You can hear me, hey, Mohammed?
Yes.
Okay, so when we put this session together, it was to try and look at the nuances and adjuncts in in pediatric brain tumor surgery. So I think, as I'll show hopefully as we go along, the intraoperative or the neurosurgery theater is quite, it's quite an intimidating place, I think. We get quite used to it, but as people sort of visit to see some of the procedures, you realize it's more intimidating than we realize. And the goal of this was, as Mohammed very sort of eloquently started off showing, minimally invasive techniques, the role of endoscopy-assisted microsurgery, and as Tony did in the follow-up talk, showed us so clearly that the benefit of intraoperative monitoring and mapping, if done correctly by the right people for the correct indication, is really, an invaluable tool. And I'm going to add some of the imaging nuances to that. And at the end, hopefully we've got some time for discussion, because, while they're leaning towards a multimodality, monitoring system, like Tony's alluded to in many of his other talks, in traumatic brain injury and other sort of neurocritical care environments, in the intraoperative environment, it probably is as relevant. But I'd leave you with a question that perhaps we can answer at the end. Can you get too much information and perhaps struggle to process it? So imaging and intraoperative monitoring and mapping and endoscopy, can that be an impedance to your sort of quality of surgery? And I want to underscore the fact that both our previous speakers have made, that your level of understanding of anatomy, experience, and technical skill, can't be substituted by, just adopting adjuncts. So you've got to make sure that you're properly trained in the basics, and then in a tiered, structured way, learn these adjuncts and master them over a long time. And perhaps that's a sort of, valuable take-home message for a lot of our young trainees. So we've heard a lot actually about endoscopy from Mohammed. We've heard lots from Tony about mapping, and I'm going to sort of combine intraoperative imaging with optical imaging a little bit, not to leave out the 5 ALA stuff. It's not the substance of this talk. I'm going to focus really on intraoperative MRI, a bit of CT, because I don't really have any experience in intraoperative CT, and then intraoperative ultrasound, which I've used quite a bit. So perhaps this quote from Dwight Eisenhower, previous American president, summarizes all of what we've been saying best, that in preparing for battle, and in many ways, complex tumors can be compared to a battleground. Having found that plans are useless, but planning is indispensable. And oftentimes, no matter how we do this, or how we plan, or how we hope things would work, intraoperatively, you've got to adjust and be able to adapt. And that's where these monitoring and imaging and mapping tools are best, in helping us anticipate problems, if not avoid them. So there's been lots published about intraoperative imaging, and really the benefit there has been because of this discordance between the surgeon's impression and the actual degree of resection. I think all of us have seen a post-op scan and thought we'd resected a lot more tumor than we actually had. There's a lot more residual. I think that's something that we've all experienced. So intraoperative MRI, is usually coupled with, and ultrasound as well nowadays, coupled with navigation. So I can't give that talk without mentioning, navigation. It's become a fundamental tool. I think most academic units now use navigation almost routinely. You require preoperative diagnostic imaging, and brain shift remains a limitation. It's useful for planning craniotomies, maybe a little less so for resection control or in hydrocephalus, for fenestration as a tool. But I think navigation as a planning tool is fundamental to all of what we've spoken about previously. So this is a case I like to use to demonstrate the value of intraoperative, specifically in my case, ultrasound. When I did this case, we didn't quite have the ultrasound. So you can see this turned out to be a anaplastic ependymoma, quite an extensive tumor. And I thought we got quite a nice resection, and under the microscope couldn't really see any tumor, but you'll see on the post-op uncontrasted CT there appears to be something that I didn't see that was there. The follow-up scan done a couple of weeks later showed there'd been a recurrence there. So the argument being, if we had some sort of intraoperative imaging, whether ultrasound, CT, or MRI scan, we may have been able to visualize that and perhaps get a more complete resection. So a lot of the literature revolves around intraoperative MRI or ultrasound, and I'll show some intraoperative CT scans, which some centers use, but I think certainly not, one of the more widely used tools. So intraoperative MRI briefly was introduced really into mainstream neurosurgery in around about 1994, with lots of reports demonstrating increased accuracy, safety of neurosurgical procedures. And they found that with frequent intraoperative image updates, they could account for brain shift, pick up residual tumor and hematomas, and sort of change the cause or trajectory of the intraoperative plan, so resect more tumor than they would have without the imaging. They range from low field to high field, so 0.2 Tesla to 1.5 Tesla, and this image impacts on the image quality as well as the acquisition time. And perhaps these two factors impact most widely, together with the cost and infrastructure requirement on where intraoperative MRI scan is used. And with advancing software technology, one can now do intraoperative MR angiography, intraoperative tractography, and even intraoperative spectroscopy. So the benefits, I think, are quite clear. There's lots of published literature supporting an increased rate of complete resection. It has been reported to modify the surgical strategy positively in about a third of cases. And apparently it improves the collaboration between the neurosurgeon and the radiologist, which is quite an important thing. The limitations are that extensive infrastructure is required. The setup costs are incredibly high. There are ongoing maintenance costs and staffing costs. The acquisition times are still pretty long, so it adds significantly to the overall surgical time. And the availability is still quite limited, so it's still seen as an esoteric tool, really in academic centers or as a research tool. So it's not widely available. 5-ALA I've included, like I said, for completeness. There's not a huge amount published about the use of 5-ALA in pediatric tumors, and by and large, it's considered less useful in pediatrics than in adult tumors. There has been a suggestion that use of 5-ALA has been associated with an increased rate of complete resection, so 36 versus 65%, and that obviously translates into a better progression-free survival over at least 6 months. The limitations are the value in low-grade tumors is not great. Limited experience, benefit, and usefulness in children. That's what the vast sort of majority of the literature suggests. And then technical aspects like blood, photo bleaching, limited depth penetration have all limited its use really in pediatric brain tumor surgery. The intraoperative CT, again, I said I've included for completeness, but there are published reports, this one quite recently, saying that it's safe, it's logistically and financially apparently a lot more viable than intraoperative MRI scan. It demands less change to the workflow and the existing setup, and is a lot cheaper, as the financial viability suggests, and has been associated with better tumor resection margins and can be used for hydrocephalus endoscopy resections. And like I've included from this paper below, once you've set up the workflow, it appears as though preoperative MRI, which is then transferred to the navigation system, then to intraoperative pre-surgery CT. These images can then be fused, used for navigation, and then the rescan during surgery. So obviously these protocols impact on how well and how useful the actual modality is. All right, and then something I've used quite extensively, and there's sort of emerging literature to suggest that there is a resurgence in intraoperative ultrasound as a real-time intraoperative tool that has significant benefit both in adult and pediatric brain and spinal cord tumors. And for the purposes of this talk, I'll limit the cases just to the pediatric brain tumors. So ultrasound is a broader tool in neurosurgery, I think, as sort of vested itself as a very useful tool, both diagnostically for the indications I've demonstrated there, intraoperative navigation for tumors, shunts all the way down to peripheral nerves. A lot of the surgical tools we use are ultrasound based, and then the more sort of high-end esoteric stuff, things like high-intensity focused ultrasound, and then the research-based neuromodulation, things like sonogenetics. So the earlier descriptions around about 1950 used something called A-mode ultrasound in a post-mortem examination, 54-year-old woman, and that's what it looked like, very much like the intraoperative neurophysiological patterns Tony showed earlier. And that was A-mode ultrasound. I would have thought that would be quite difficult to interpret when you're using a probe, but the description by French and Wild really sort of set the kind of the platform or the foundation for advances in further publications. About 30 years later, with advancements in the technology, B-mode started to become more mainstream in medicine, and you can see the images were then something we were more used to, but less sort of comfortable with, considering that, we use MRI and CT scans mostly. And this publication, 82, found that it was able to identify the pathology clearly, and ultrasound, was apparently at that stage an important new tool in the operating room. This has advanced significantly, and a lot of the work underscoring this has come from the Norwegian group in Trondheim, and they've aimed to combine intraoperative 2D ultrasound with preoperative MRI scans, combined through a navigation system to provide a 3D ultrasound. And there's increasing evidence in the literature to suggest that this modality, this 3D ultrasound, is incredibly useful to distinguish tumor-brain interfaces. And this was done in the study by the Norwegian group, with biopsies done at the tumor-brain interface, pre, intra, and post-op. And they found that it was excellent in identifying the tumor borders with a good sensitivity intraoperatively and a good specificity post-operatively. And they found that it's useful but limited in GBMs. So in my practice, I've used ultrasound widely for ventricular catheter placement, endoscopic guidance, vascular KI decompressions, intramedullary, and like most tools that you use, to augment your intraoperative plan, the more you use something, I think the more comfortable you become with it, and the more indications start to unravel for that. So what does one require for use of an intraoperative ultrasound? Firstly, you need a good surgical window. In the neonate, this is provided naturally by the fontanelle, but generally the craniotomy itself may need to be extended slightly to allow for, for the probe, but with the modern probes, the high frequency probes tend to have smaller footprints, so you can use them, within your standard craniotomy. And I found increasingly that I don't need to increase the size of my craniotomy to image. Sterility, again, these follow protocols intraoperatively, but it's very important that the probe be sterilized correctly. Some of the probes in the market can be sterilized together with the rest of your instruments. Others need to be placed through a sterile sheath. The image quality, spatial resolution, the probe frequency, and probe size is something you need to become, quite familiar with. And these are things that I think people learn best during workshops that are focused on teaching this type of skill. Something we've done quite a bit of, and I've got good feedback in terms of, the initial learning curve is quite steep, but once you get over that, I think it becomes very, very sort of indispensable as a tool. And then things like image display, the type of probe, and like I said, the user experience is quite important. So this is a slide I've used courtesy of Gammon Ungsgaard, and he's shown, the position of the craniotomy. If it's horizontal, it tends to provide best imaging access. Things like removing the spatulas, air bubbles, blood, these improve the specificity or image quality. It's nice to have a clean cavity without any blood spatulas or air bubbles, and the imaging quality is then improved dramatically. So this is the case, an adult case, but I've just used this to demonstrate. This is what turned out to be a glioma. This is what the intraoperative ultrasound imaging looks like. You can see the borders superiorly and medially are quite clear, but tend to get a little hazy as you get towards the depth. And these are the kind of things that the type of probe selection impacts on quite significantly. Like I think Mohammed showed earlier, I think something I found incredibly useful is the duplex function, not just the duplex Doppler function, but also the color Doppler function, which doesn't show necessarily flow direction, but shows flow quality. And this is great. I'll show in a few slides as we go along how one can differentiate, neighboring vessels versus vessels that supply the tumor. So it can help you differentiate between vessels that you can sacrifice and those that you need to keep. So this is what the same case looked like intraoperatively. You can see the residual tumor here. This artifact I'll speak a little bit more about later. As we resected more of the tumor, you can see that residual was less, but that artifact can still be quite disconcerting. That's what the pre and post-op scan looked like. So we managed to resect that completely. This is a pediatric case, choroid plexus papilloma that extended to the lateral ventricle and down into the third. That's what the coronal MRI scan looks like. You can see the comparable imaging on an ultrasound is really very comparable, considering the sort of tremendous difference in cost. But you can see the lateral ventricle tumor there, the third ventricle over here. And with the Doppler function, you can actually see the vessel that's demonstrated on the MRI scan a lot better on the actual duplex function. So I think in some ways, once you get more comfortable with the ultrasound imaging, it can provide you perhaps even better quality imaging if you know how to interpret them properly. So this is an example of the power Doppler showing this is a posterior fossa tumor. You can see the pica vessels bilaterally, and these are tumor vessels. So as you become more comfortable with them and you can integrate them anatomically, it helps guide you in terms of which vessels are tumor vessels and can be sacrificed versus those that are, you need to preserve. And it's quite helpful post-operatively as well, just to document, the presence of these vessels pre and post resection. Again, this is a posterior fossa tumor. You can see the ultrasound image intraoperatively compared to the pre-op MRI scan. That's intra-fourth ventricle. The plane is different, but the image consistency is pretty good. During the resection, thought we resected a lot of the tumor, maybe some left along the margin there. The ultrasound suggested that there may be some tumor along the margin, which I then resected. And you can see that looks a lot better on the subsequent intraoperative ultrasound, and that's confirmed by a nice clean fourth ventricle. You can see all the way to the aqueduct there. This is the case we did with both ultrasound and intraoperative neurophysiological monitoring. The tumor was sort of stuck to the floor of the fourth. We decided to leave that. You can see the intraoperative ultrasound confirms that residual there. So when we did the post-op MRI scan, that tumor left behind wasn't a surprise. So it helps with anticipating and getting a more complete idea of what's been taken and what's not. This is the case with a complete resection. That's the intraoperative ultrasound showing a nice clean cavity. Line that with Surgicel, which isn't a sort of standard thing, but in a lot of cases we will leave some Surgicel, and you can see the post-op MRI scan confirming a nice clean tumor cavity with the Surgicel lining on the top there. So this artifact I was talking about with normal saline towards the end of the, or at least of the tumor bed, tends to be quite difficult to interpret and differentiate from residual. And there are kind of novel acoustic coupling gels available now on the market, which have been developed in using these gels. And they tend to be more aligned with brain consistency and brain acoustic properties. So they have fat infused into the solution, and that does quite a bit to improve this artifact imaging. The point being that as this develops, the quality of imaging from ultrasound will continue to get better, and I'll show some of the more advanced techniques towards the end. So there have been a number of studies as well published confirming intraoperative ultrasound and its correlation with post-operative MRI scan. And generally the consensus with these papers is that there's a good correlation between intraoperative ultrasound and post-operative MRI in experienced user hands. This paper from Ali Asghar Mayadi, who's done a lot of work driving the value of intraoperative ultrasound in brain tumor resection. He runs the cancer hospital in Tata Memorial in Mumbai, and they do a huge volume of brain tumor resections. And this compares intraoperative MRI versus ultrasound. And in some ways, they found that with experience and comfort, they got better imaging quality with the intraoperative ultrasound than they did with the MRI scan. Again, it doesn't, work for all comparisons, but with increasing experience, it becomes a lot more useful as a tool. So this work by the Norwegian group demonstrated the ability of navigated 3D ultrasound to delineate gliomas and metastases, and they found that it correlates very well with histopathology as well, not just with imaging interpretation. Again, this paper shows that the combination, when they compared intraoperative MRI, 5-ALA, and intraoperative ultrasound in glioblastoma surgery, they found that the intraoperative ultrasound in their hands, by the metrics that they had used, was the most useful in guiding their resection margins. So advances in imaging and ultrasound imaging have been things like contrast enhanced ultrasound, elastography, strain measurement, and then the extended usages are things like vascular lesions and KRE1 malformations. 3D ultrasound, which I've alluded to previously, has established itself in many centers as being able to improve the radicality of tumor resection and perhaps even align itself better with the surgeon's impression or surgeon's orientation. In my experience, and in quite a few centers that use intraoperative ultrasound, if you become comfortable enough with the 2D orientation, perhaps you don't need the added integration into a navigation system or an MRI scans, preoperative MRI scans. So contrast enhanced ultrasound, just briefly, you can see the imaging quality by comparison. And Francesco Prada, who's done a lot of this work, emphasizes the fact that we wouldn't really use, an MRI scan that wasn't contrast enhanced in a patient with a tumor. And by the same sort of thought process, ultrasound, contrast enhanced ultrasound produces a better quality of imaging, by that same margin. The difficulty is the contrast agent isn't licensed, in all countries yet, but I understand that this is something that's being worked on. And once it becomes mainstream, I expect it will embed itself in the brain tumor surgeon's armamentarium. So it's supposed to provide better lesion detail, better vascular imaging. Contrast medium, like I said, is still quite expensive and not widely available. Strain elastography exploits the elastic properties of biological tissue, so it uses that to demonstrate the difference between normal brain and brain tissue. So you should be able to, differentiate those borders a lot better. The algorithms unfortunately differ quite a bit. The acquisition is motionless, which is still good, but the software is still in a development phase. But should it reach that phase of mainstream usefulness, I think it's incredibly useful then to try and differentiate, like we can see the images here, brain tumor from normal brain surrounding it. Elastography, the difference between elastography and strain is that you need motion to generate, elastic, to kind of bring out the tumor elastic tissue. This paper found that it was more useful than, or at least more useful in identifying lesions which were not identified in the MRI scan. This was a case of focal cortical dysplasia. They used the sweeping motion over the area to image, and they induced this tissue response. And this paper found it quite useful to differentiate or at least identify these lesions. So to summarize, then, I think intraoperative imaging in brain tumor surgery is an incredibly valuable adjunct, but like the point was made earlier, it is an adjunct and no more than an adjunct, and shouldn't, take away the value of actual, experience and anatomical knowledge. But it has been demonstrated that the safety margins are improved, resection margins can be better in experienced hands. There's a broad scope of applications in neurosurgery, not just brain tumors, but hydrocephalus, endoscopy, hematomas, etc. Ultrasound, particularly, I find in our context, and I would go so far to say that in an African context, it is perhaps the most attractive of these. It's safe, it's cost effective, it's portable, has diverse applications from diagnostic to guiding surgical resections. So I think it's certainly worth making the effort to practically integrate this tool into our surgical practice. And I'm going to wrap up there. So thank you very much. If there are any questions, I'm happy to take them.
Thank you, Llewellyn, for this very nice and illustrative presentation. And do we have any question from the panelists?
Yes, we have one from.
Yeah.
Go ahead.
Yeah, John, please.
Yeah, Uday has a question. Uday, you want to ask that directly, Uday, or you want me to read it? Uday says, go ahead, Uday.
Yeah, intraoperative focused ultrasound has come up nicely in treatment of patients with GBM and tremors. Any experience in that, sir? What?
Yeah, so look, the literature supports the use of high intensity focused ultrasound for essential tremor. I mean, there was a New England Journal of Medicine article published from the group in Virginia. Broader, yeah. In GBM, unfortunately, it's promising, but it's still very much a research tool. So there are a number of ways that it's used. Remember, it's completely different to the way intraoperative ultrasound is used diagnostically. So opposed to high frequency, you tend to use a very low frequency and focus the beam. The difficulty is at that frequency, it heats up the scalp. So it's very difficult to control the scalp heating and focus the beam. So when Lexell started out with the Gamma knife, he initially used focused ultrasound. So it's not a new modality. The difficulty then was controlling the focus, and the difficulty nowadays still remains controlling the focus. So the usefulness in GBMs is not just as a sort of thermal ablation, but also disrupting the blood-brain barrier so you can get chemotherapeutic agents through to the brain. So potentially, you know, if you read all the stuff published, it appears as though it's a panacea that can cure, you know, all sorts of brain tumors. But I think, you know, there's a long way to go in refining it. I think it's incredibly promising. But even now, there are very few, well, not very few, it's growing in numbers, but the widespread availability and use in brain tumors is still fairly limited.
Thank you, sir.
There is another question, from Javier. If you have any experience with fluorescein during the surgery?
Is that to me, Mohammed?
Yeah.
Yeah. So look, I've probably, you know, when I was at Red Cross, we used, I in one case used, I think Tony will remember the case, 5-ALA, and didn't find it to be that useful. The indication may not have been great. It was a low-grade tumor in the end, and you need to have a microscope that's aligned, so the software needs to be updated. So I don't have a huge amount of experience using 5-ALA. It's also quite expensive, we found now, doing a cost analysis, comparing, you know, ultrasound, other imaging modalities, physiology, and 5-ALA. So I'm not sure that it justifies that risk. Perhaps the other guys, Mohammed or Tony, can just give us a comment on.
Yeah,
whether
I have done actually 17 cases of pediatric brain tumors with 5-ALA when we had the Leica microscope like a few years ago, and I found it useful in one of the cases was atypical meningioma and medulloblastoma and anaplastic ependymoma. In these three subjects, especially, 5-ALA was very useful. I found it. We didn't have any real complication from the photo complication from the 5-ALA in children. We usually have this in the very beginning when we got the microscope. We had from the company as a gift 10 ampoules of 5-ALA, where we can use. We used each one for 2K a day. But as in general, I could not reach a conclusion if it is really helpful in most high-grade tumors or not. But of course, in low-grade tumors, it was useless. I used it once in a pilocytic and in a astrocytoma, grade 2. Was in medulloblastoma, sometimes it shows, it lightens up, but not in most of the cases. It was only 5 cases of medulloblastoma. I found it helpful in 2 of them. And one, as I said, anaplastic ependymoma and atypical meningioma. So it doesn't justify the price of it, but I know that some hospitals now made their own 5-ALA, and there is an Indian version of the 5-ALA which is much cheaper than the one used, but it is still off-label in children. So what we are doing now is identifying, using the 5-ALA, we're trying to do a project in pontine gliomas during the radiotherapy. This is a project we are working on with our radiotherapist, that using 5-ALA during the radiotherapy for pontine high-grade gliomas. I don't know if Tony have any experience with this. Is Tony still here?
I'm not sure he is. Moody, you have any experience?
No, I don't actually. Haven't used the 5-ALA at all.
Yeah.
The question I was going to ask, one of your slides showed the small portable ultrasound that is almost like it's on a laptop. Or you have used it, and how useful is it in showing you the detail?
So you know, Moody, a question that often comes up, and I think from a lot of our sort of African colleagues, is can the ultrasound machine that I have in my hospital be used, you know, intraoperatively? And the answer, broadly speaking, you know, is yes. You may need to modify the probe, but those portable machines that, you know, the anesthetist wheel in to find a blood vessel, the image quality should be good enough. So the machine that we have intraoperatively is the Philips Epic Elite. It's got a high-end machine and provides really good quality imaging. But, you know, if you look at the complete opposite to that, the Butterfly project is something that was launched in the United States, where you have a probe that you plug into your cell phone, and it's really the probe that has the software. And apparently that imaging quality is good enough for a lot of these things. So, I think the advancement in technology almost takes it to the cell phone level, even beyond the laptop.
Great, thank you.
I think there is now a joystick probe which you can scan the cavity of the tumor. This one I just got last year from BK. It's very helpful when you have the cavity of the tumor, and it's like an L-shaped joystick, very small probe that you just insert inside the cavity, start scanning all around the wall of the cavity. Have you had any experience with this, Leon?
Not a joystick cavity, Mo. So I use the C85 probe, which is a relatively small high frequency probe, and the hockey stick, which is probably an equivalent to what you're talking about. And I found that really useful, for superficial tumors. The issue with that is the frequency is pretty high. So the image quality is great, but you can't really see, at a suitable depth. That's a limitation with the high frequency probes. So I think having more than one probe is really useful. So, medium to high 8 megahertz frequency probe that you can use for depth. And then, like you're saying, the hockey stick high frequency for superficial tumors, specifically in spinal cord tumors. I've used that hockey stick and found it quite useful.
Okay, Mohammed has a comment or question. Go ahead, Mohammed.
Yes. Well, generally speaking, basic neurosurgery does not need much of the new technologies. And this could be compensated for by an adequate knowledge of neuroanatomy and fine handling of tissues. Fine handling is a secret, since the brain tissues will respect you as long as you respect them. We have the best example in shifting from using intermittent retraction and prolonged retraction and the consequences of that. A thorough knowledge of the white matter anatomy and dissections are of great help. The visualization of the lesion or improving the functional important blood supply visualization through the trajectories is very important. As it was shown, ultrasound is quite important when it's used intraoperatively, and it is cost effective. Sometimes you do need navigation. In most, I would say 95% of cases, you don't need. In the 5% where it's a critical situation, you do need this new technologies. And remember that some recent microscopes allow even adequate instantaneous assurance of the resection safety margins depending on the histopathological confirmation of this. However, this may await large-scale, multi-center, prospective, double-blind statistical confirmation. Besides, they are damn expensive for our continent so far.
Yeah, I would agree with you, and especially I think, which I just disagree in a point, that in the recent protocols, you need to have a near total or a total resection. In case of kids, especially with new protocols, the resection, the degree of resection correlates directly to the prognosis and to the adjuvant. As you can see, blastoma less than 1.5 centimeter left behind, then you can go to a low protocol chemoradiotherapy. More than 1.5 centimeter, then you shifted the patient to a high protocol with prognosis 50%. So shifting from 80% 5-year survival to 50%, and you leave more than 1.5 centimeter of the tumor. And using this adjuncts in the operating theater would get you the maximum safe resection. So whenever possible in children, I would prefer using all technology, because this is depending on the prognosis, survival, and the quality of life. Maybe in adults, we can use less adjuncts, as Professor Faye said, but I think in children we have to have the maximum and the safe at the same time. And this could be correlated to the adjuncts used inside the operating theater whenever possible. As Llewellyn showed, the ultrasound is very user-friendly. It doesn't need a high learning curve. I just advise the new users with ultrasound, as I did many years ago, to introduce their radiologist with them in the OR, interpret the image in the beginning. After a few cases, then you get very user-friendly with this. You can get accustomed to using the ultrasound alone, and you can interpret images by yourself. And with the high-tech ultrasounds nowadays, you can substitute the high-cost MRI and CT, and especially children in spinal cord and brain tumors. So it's really very helpful to have them inside.
Okay. Thanks,
Okay,
Mohammed. John, are there any other questions that we may have missed or new questions?
Okay, I don't know if you asked this question already. What possible complications have you faced from implanted electrodes? Was that question asked yet?
I'm not sure if Tony's still here, but if he wants to answer that question, I'm not sure.
Yeah, I'm still here.
Yeah.
Yeah, I haven't had any problems in our practice, and this goes back a decade or so. I think we had a near miss where an electrode was kind of left in a patient's arm, and the cord was just cut. That didn't come into any trouble, and we kind of realized it quite soon. Yeah, we haven't had any problems, but there are a couple of things that one has to avoid. So particularly with the hook wire electrodes that we put in the soft palate and the tongue, we learned from other people's experience not to use the bigger needles. I think it was Dackling Pang that had told me that they had a patient who had a kind of post-operative tongue swelling, a tongue hematoma, but those were with the big those are the big electrodes, and since we only use the hook wire electrodes, and those are small, so we've never run into any trouble there. So no, it's low risk. I mean, you need to be trained specifically how to put the electrodes in, particularly when you're putting the somatosensory ones. The muscle group ones tend not to be too much of a problem. So you need to know how to put them in, but if you've been trained properly, then you shouldn't run into any trouble.
There's a follow-up question. What would you consider to be the average cost for setting up a standard monitoring unit?
Oh wow, that's a tricky question. I've got no idea what the current costs are.
Okay.
When we bought our system, it was about 800,000 rand. So that would be what, about $40,000? No, it'd be a bit more, maybe $50,000.
Significant.
Yeah, so it's not it's not a small amount of money, and that, I mean, that's a robust system. You probably could get by with less. As I said, when Moody and I were chatting about the kind of resource constrained environments, mapping with an oddment stimulator requires some outlay for the oddment stimulator, which is nowhere near the same cost. I mean, that's much cheaper, and it doesn't. Most importantly, it doesn't need consumables. So that's often a big problem in resource constrained environments. You can find somebody who's going to either donate to you or buy a unit for you, but it's the consumable costs that can be quite constraining. So with mapping, it cuts down on the consumable costs, and then it makes it quite viable.
Okay, it sounds like there's a lot of interest in neurophysiology. So if there's any neurophysiologist here that wants to do a webinar on neurophysiology, just hang around after the webcast and we'll talk about it. Okay, thank you.
Great, John. Are
Okay,
there
I
any
think we
additional
reached the end.
questions?
Go ahead. Was someone trying to ask something? Go ahead. Oh, perhaps not.
Mohammed, did you want to say something?
No, the
No,
great,
just
go ahead.
Yeah. Okay. Look, I'll perhaps make a comment. So, firstly, thanks, John. Thanks, Mohammed. Thanks to our excellent speakers, Tony Figaji, Professor Al-Fiki, Moody Qureshi, and Mohammed, my co-host. I think it was a fantastic webinar, well attended, and I think just spectacular discussion around it. And like you said, John, intraoperative adjuncts, particularly intraoperative monitoring, is something that's quite useful to perhaps run a separate webinar on. Okay, I think with that, maybe we should aim to, we've just passed our allotted 2-hour slot, so we'll aim to end the webinar there. And thanks to all our attendees and panelists, and you, John, as well, once again.
Okay, well, do we have another webinar planned? Yeah, Llewellyn?
Yeah, so we
usually
run these on a monthly basis. Mo, maybe you wanted to say something more about
the second Tuesday of each month. So we have it always at 7 p.m. Egypt and South Africa time, the second Tuesday of every month. So that's how it works with it.
Okay, very good. I think thanks to Llewellyn and Mohammed and everyone else that talked and spoke. And so we'll see you next time. And hang around after to network.
Thanks all. Bye.
We'll close.
Thank you very much for excellent presentation.
Thanks.
Okay.